On behalf of Dr. Guy Mintz and myself, we would like to welcome you to the National Lipid Association's The Lipid Panel. My name is Merle Myerson. I'm a cardiologist and lipid specialist, as is Dr. Mintz. The Lipid Panel was conceived to be a lipid clinic conference similar to educational conferences held at academic medical institutions. For both those who have these conferences and for those who do not have in-house conferences and colleagues, the Lipid Panel is a great way to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, find out the most up-to-date information, and come together with those in the lipid and cardiometabolic community. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, and sometimes even common presentations of common conditions. And we will try to cover as many important topics every lipid specialist needs to know. If you have any thoughts about these topics to be presented, please be sure to let us know. The Lipid Panel offers CME and is held on the last Tuesday of each month, except for December, July, and August. Tonight, we're going a week early because of the Thanksgiving holiday. All sessions are taped and available for viewing on the National Lipid Association website. So I'd like to introduce our panelists tonight. We have Dr. Nick Marston. He's an associate physician in the cardiovascular division at the Brigham and Women's Hospital and an instructor of medicine at Harvard Medical School and an investigator of the TIMI study group. His research interests include novel lipid-lowering therapeutics, genetics of cardiovascular disease, and translating genomic discovery into clinical practice. In addition to his research work, Dr. Marston attends in the Cardiovascular Genetics Center, where he cares for patients with FH, premature coronary artery disease, and inherited cardiomyopathies and arrhythmias. Dr. Dan Soffer is well known to all of us. He's our past NLA president. Dr. Soffer is a clinician and educator, clinical associate professor of medicine in the Division of General Internal Medicine and Translational Medicine and Human Genetics at the Perelman School of Medicine at the University of Pennsylvania. He is Director of Education for Preventive Cardiology and Clinical Lipidology at the University of Pennsylvania, and co-director of the Preventive Cardiology Fellowship Program at Pennsylvania Hospital, and co-director of the SOM Foundation's of Culinary Medicine course. Kaye-Eileen Willard is also well known to us. She is the incoming NLA president. She is chief of staff at All Saints Hospital at Ascension, Wisconsin Healthcare System. She served as chair of the Department of Medicine for many years and developed the first lipid clinic there. Dr. Willard's work is a blend of administrative, operational, and clinical leadership roles. She leads a regional medical executive committee encompassing 8 hospitals and chairs the Joint Chiefs of Staff. Zimmerman is an MD and PhD. He's a professor in postgraduate program in cardiology at the Federal University in Rio Grande do Sul in Brazil. He is also head of the clinical trials unit at the hospital Moinhos de Vento, College of Health Sciences in Brazil. He completed a postdoctoral research fellowship with the TIMI group at the Brigham and Women's Hospital in Boston. So welcome all. I'm going to turn this over to our moderator, Dr. Willard.
Thank you very much, Dr. Myerson, and welcome to everyone. It looks like we have a really nice turnout developing tonight for a very important, interesting, and relevant topic for all of us who practice clinical lipid specialty medicine. So we are going to start with a case presentation tonight. And I will turn it over to Dr. Zimmerman to get us started.
Thank you, Dr. Myerson. Thank you, Dr. Willard. So the case today is of a 62-year-old asymptomatic female presenting for a lipid consult. On her medical history, she is overweight. She has a history of hypertension, diabetes. She's a current smoker, and she's had an NSTEMI 2 years ago with PCI, 2 drug-eluting stents in the LAD and the RCA. Her current medications are atorvastatin 80 milligrams once daily, aspirin 81 milligrams daily, hydrochlorothiazide 25 milligrams daily, and dapagliflozin 10 milligrams daily. In terms of lifestyle, she walks to work 2 blocks every day, but is otherwise sedentary. She has a balanced diet during meals, but says she frequently snacks on processed foods. She is a current smoker, has smoked 1 pack per day for the last 20 years, and drinks about 1 drink per week on social occasions. In terms of her family history, her father had an MI at age 58 and died from lung cancer at age 82. Her mother currently has diabetes and is 83 years old. She has no siblings, and she has 2 children, a 31-year-old woman, 27-year-old man, both in good health. Now, on the day of the visit, in terms of her vitals, she had a BP of 132/82, a heart rate of 86 beats per minute, a BMI of 28.2 kilograms per meter squared. Her physical exam was otherwise normal S1, S2, no murmurs, lungs were clear to auscultation, extremities were warm, and there was no corneal arcus, xanthelasma, or tendon xanthomas. Now on to the lab results. The CBC, electrolytes, LFTs were all unremarkable. Creatinine was 1.0 with no detectable albuminuria. A1C was 7.1, HSCRP 2.1, so slightly elevated. The ECG was unremarkable, and the echocardiogram was within normal limits with a preserved left ventricular ejection fraction. So, of course, now we need a lipid panel. So I guess the first question here to you all and the audience is, which test would you order in addition to a standard lipid panel? Would it be a lipid panel only? Would you add apolipoprotein B, or would you add NMR spectroscopy?
So this is a great opportunity for polling our audience. And I think we can put that into place. Which test would you order, as Dr. Zimmerman said, a lipid panel only, ApoB, an NMR spectroscopy, or I'm not sure? All right. Well, very intuitive there, seeing as the topic of our discussion tonight is apolipoprotein B. So I see that 80% of our audience has selected that. Given that, let's go ahead and move on with our patient discussion here.
Kaye-Eileen, can I tell you, I think we may have a little selection bias here in terms of how the answers went. People chiming in to watch tonight probably have a special interest. It may account for why ApoB is such a high number, because I don't think it's really measured quite that frequently in general care.
I would say that is definitely the case, and we obviously have a very sophisticated audience with us here tonight. All right, let's move to our next slide.
Okay. So let's talk a little bit about ApoB, but before we do, let's remember what LDL cholesterol is before we move on to ApoB. So as a reminder, LDL cholesterol is a surrogate of LDL particle count. The top part of this figure, you'll see an LDL particle, which includes an ApoB, includes phospholipids, free cholesterol, triglycerides. In the bottom part of the slide, you'll see actual LDL cholesterol, which is the amount of cholesterol present in LDL particles, which is a convenient surrogate of LDL particle count, but not a direct measure of LDL particle count. Now, here's where ApoB comes in, because ApoB is the main structural protein on all atherogenic particles. Each atherogenic particle has one ApoB on it, as you can see in this figure, showing an LDL particle with an ApoB in there. So Since each atherogenic particle has one apolipoprotein B, when we quantify ApoB, that is a direct measure of atherogenic particle count. And that matters because atherogenic particle count, or the concentration of atherogenic particles, is a stronger indicator of atherogenicity than LDL cholesterol. Here's one hypothetical example of two patients. The patient on the left and the patient on the right both have an LDL cholesterol of 100. Both have the same amount of cholesterol in their LDL particles. However, the patient on the right has a higher particle count, has more ApoB, and therefore is at increased cardiovascular risk compared to the patient on the left.
So, Andre, let me ask another question here. I know we're going to be discussing this a little bit more as we go on, but more commonly available is non-HDL cholesterol. And how would you differentiate and help our audience understand benefits of one versus the other?
So first, we need to remember what non-HDL cholesterol is. So LDL cholesterol is the amount of cholesterol in LDL particles. Non-HDL cholesterol is the total amount of cholesterol in all particles apart from HDL. So it also includes other atherogenic particles such as VLDL, IDL, and chylomicron remnants. It is more correlated to ApoB and more correlated to ASCVD, but it's not a direct measure of particle count. It's the amount of cholesterol in atherogenic particles. So it is also a better measurement than LDL cholesterol, but it still doesn't get into the actual concentration of atherogenic particles, ApoB, which seems a better indicator of atherogenicity. But I'll open up to discussion from others as well.
That's an excellent explanation, and I agree with everything you said. I think this diagram nicely highlights the discordance you can see between LDL cholesterol and ApoB, but that discordance can also be present for non-HDL cholesterol and ApoB for the same reason you point out, that the LDL cholesterol and non-HDL cholesterol are measuring cholesterol content. ApoB is actually measuring the concentration of the total atherogenic lipoproteins. So LDL or non-HDL cholesterol, you can see a range of ApoB from 30 to 40 milligrams per deciliter, like you've shown here in this example. And that could be the difference in how you think about a patient's risk or whether you intensify therapy or not.
Kaye-Eileen,
The other thing
I think Nick and I were good writing partners on this project because Nick is fantastic with the data and really helped us put the data together for the paper very nicely. And I always like to stay at concepts and mechanism. And my simplistic way of thinking about why ApoB might be a better indicator compared to non-HDL cholesterol comes from understanding this one very specific aspect of atherogenesis, which has to do with the concentration gradient, the difference between the concentration of particles in the lumen compared to the intima. That's not the only thing that drives those lipoproteins into the intima, but it's a very important driver of, it provides the sort of driving force to push those particles past the endothelium into the intima where atherosclerosis is happening. And so the number of particles is really going to be the thing that drives that, not the cholesterol content within those particles.
Agree. And the other comment that I always think is important is when we have conversations with our patients, understanding that we want to move to shared decision making with our patients so they understand what it is that we're testing for as well as managing. I think this is a concept that is very understandable for our patients if we phrase it exactly in these terms. So let's move on then to our actual data for this particular patient.
So back to our patient case, we do a lipid panel, including ApoB and Lp(a), as everyone here suggested. Total cholesterol is 143, triglycerides 311, HDL-C 32, LDL-C calculated by the Friedwald formula 49, non-HDL-C 111, ApoB 90, and Lp(a) 75 nanomoles per liter. Reminders, the patient was on atorvastatin 80 milligrams daily.
So this is a high-risk patient. I mean, based on the description that you've already given us, Andre, this is a high-risk patient, and I think that LDL-C level is a little bit surprising there. We definitely see a discordance with both the non-HDL as well as the ApoB. So can we really believe that LDL-C based on the Friedewald equation?
No, I think we can say pretty strongly that that is probably not an accurate representation of the cholesterol content of LDL, nor is it an accurate representation of the atherogenicity of this lipid profile. So, it took a long time at our institution, but we have finally sunsetted the Friedewald formula because of cases just like this. And there are there's two major recalculations that do a much better job at LDL cholesterol than the Friedewald formula, and that is the Martin Hopkins formula and the Sampson NIH formula, both of which can be plugged into EMR databases and give you a much better expectation of the atherogenicity based upon LDL cholesterol. And then, of course, LDL cholesterol, we just got finished saying, may not be the thing anyhow. So even if we have a better calculation of LDL cholesterol, are we really getting at the thing that's driving atherogenesis the most? It's a pretty good estimate of that, but we have better markers of that phenomena. So LDL cholesterol by a better calculation and the other markers that are seen here.
So we also have a question from our audience on the subject of discordance, asking, we think about this for all of our patients. There are varying opinions within the group of this particular individual regarding utility of NMR. If the LDL particle count is discordant, but ApoB and LDL-C are concordant, what do we think about this?
Are we jumping right into a discordance right now? we can.
We can, or as I say, the question came up from the audience, or I know we're going to be discussing this later, so we can certainly move into the remainder of the patient presentation as well.
Maybe let's focus just on these markers that we have in front of us, and then we'll talk about where one marker may have some benefit over another. So I chimed in about the LDL-C. Nick, you wanna throw something out about non-HDL?
Yeah. I mean, I think as Dr. Willard says, you see an LDL cholesterol of 49, and you think, oh, you're in great shape, right? This is a patient who's high risk with a prior NSTEMI. We've got the LDL even down below the aggressive threshold of 55, so you may feel content, right? But if you look at the ApoB, it's 90, it's discordantly high compared to the LDL cholesterol. It tells you there's still a lot of atherogenic particles in the bloodstream, and there is more work to be done. And where that is coming from, if we look at the rest of the lipid panel, is likely from VLDL particles. And those are captured on the lipid panel by triglycerides. So we see the triglycerides are high at 311. Triglyceride-rich lipoproteins are atherogenic. VLDL is really the biggest one, but also chylomicrons and chylomicron remnants, IDL. So these are particles that carry per particle just as much risk as an LDL particle. So while they're less of a proportion of our atherogenic concentration, we do need to lower them and pay attention to them. So I think in this case, the discordant elevated ApoB along with the high triglycerides tells us that may be the axis of lipid risk that we need to address next.
All right. So Andre, shall we move ahead with our slides?
So now the question is, LDL is low, at least in the formula that was presented. Would you consider intensification of therapy in this case? And I think the consensus here is that this is a very high-risk patient and that you would, in some part, consider some additional therapy. Is that right?
I certainly think that sounds like a reasonable idea. Ask our panelists.
Yeah, sure. This push, I agree. I think you said earlier that you thought of this person as having high risk. I dare say she might even be thought of as having very high risk, depending on the parlance you prefer. But I would say that one of the aspects of her care that's going to be very important is reducing her LDL as much as we can with available therapies that we know are effective for reducing cardiovascular disease. And I think there's room to go, and the guidelines and the more recent ACC expert consensus decision pathways give us some thresholds for when we would intensify her care.
So we've determined we need to intensify therapy. Where would we go from here as far as our specific aspects of management?
I think there's a couple of options. And first of all, I do think using the other equations can be helpful because it might feel odd or unusual, or especially if you're trying to get insurance coverage for the LDL lowering therapy, but your LDL in the chart is 49, that may feel uncomfortable. You may get pushback. So, using some of these other calculations or citing the ApoB when you do order further LDL therapies is important. Looking at the ApoB of 90, this is a patient that their ApoB goal based on the MNLA recommendations or expert consensus just put out should be at least below 70, if not below 60, if we're calling for very high risk. So we're still a ways from that. One way that you could tackle this aggressively on top of already on high intensity statin would be a PCSK9 inhibitor. You're going to get a nice robust LDL reduction. You're also going to get some triglyceride lowering. The triglycerides were elevated, and overall a robust reduction in ApoB that's going to put you below your goal for even a very high risk patient.
Yeah, that's a good point about that's a good point about making sure that you have full coverage for the types of interventions you're talking about. So, for example, if you want to add a inexpensive therapy to lower the LDL further, nobody has any thoughts about it other than you and the patient. However, if you're using an expensive therapy, now all of a sudden you're bringing other people into the conversation, namely the payers, and they are going to have some very, very specific thresholds from their algorithm that allow you to access other types of care that may be a little bit more pricey in the current standards. But the thresholds to pay attention to, I think we should start with the guideline-based thresholds and expert consensus decision pathway thresholds that have been updated since that time, and then just remind everybody that in our ApoB expert consensus paper that we gave some ApoB specific thresholds. So just to remind you, so this patient is very high risk because she has established ASCVD. She's had an event and revascularization. She's an ongoing smoker. She's got all the things, right? Hypertension, diabetes. I can't remember all the things she's got, but she's got them all. So she has multiple risk factors. She should be put into the box of she's at very high risk. And the threshold for intensifying therapy based upon the 2018 guideline is an LDL cholesterol of greater than or equal to 70 milligrams per deciliter. But that was updated in the 2022 ACC expert consensus decision pathway that suggested that in the very high risk population that an LDL cholesterol threshold of 55 milligrams per deciliter is more appropriate. So that's why it matters how we measure the LDL cholesterol. To Nick's point earlier, using the current Friedenwald formula, she's already below that threshold. So based upon that standard, there's nothing else to do. And yet when we recalculate her LDL cholesterol, we can see, we didn't show that number. Andre, I can't remember if we have a slide that shows what her recalculated. There we go. Look at that. On demand. Her recalculated LDL cholesterol is 74 milligrams per deciliter. So even if we use the older guideline of 2018, we can see she's above that threshold that tells us for sure there's more to do. And if you want to dive in a little bit deeper, you can see she's above the threshold for non-HDL cholesterol too. And you have to go a little bit into the Wayback Machine. But if you may recall, after the 2013 guidelines were written, the NLA issued a recommendation suggesting that, based upon our understanding in 2014, we actually thought that non-HDL cholesterol should be the primary target. And that for the most part, when you treat individuals to a lower non-HDL cholesterol, almost everybody will have already achieved the LDL cholesterol you want. So if you use non-HDL cholesterol as your primary target, by that line of thinking, you'll make sure that you'll cover all of the patients based upon LDL cholesterol. But that's sort of a sunsetted approach, and the current approach is based upon that 2018 guideline and the 2022 consensus, expert consensus decision pathway, both of which would tell us that this patient is above the threshold. So there's more to do. And whether or not we need ApoB in this context, based upon this particular case, I think we already have evidence based upon the LDL cholesterol when it's recalculated, and the non-HDL cholesterol, which are both free tests where we can answer that question. But if there was any concern about maybe we're leaving some important treatment on the table, yeah, we also know from looking at the ApoB that we need to do more for this patient. I don't know, Nick, whether you have some thoughts about what you would do next to lower these things.
And this may be a good opportunity to poll our audience as well as have this discussion. There we go. So, what would be your preferred lipid-lowering treatment in addition to the atorvastatin 80? One choice only. Diet plus ezetimibe, diet plus a PCSK9 inhibitor, or I'm not sure. While we're waiting, any other comments, Nick, as far as additional thoughts in terms of next action steps?
Have a good sense of how far you are from your goal, because you see here the answers are pretty split between adding ezetimibe versus adding PCSK9 inhibitor. And I think this is something we all are deciding about multiple times a clinic. And it's kind of like how far do you have to go with your LDL lowering to get to goal, or your ApoB lowering, however you want to look at it, or non-HDL. Ezetimibe is a modest benefit. It's easier to get. It's less likely to get you far. So if you only have to get another 10, 15 milligrams per deciliter, or 15-20% reduction, then that could get you there. However, if you need to go further, like I think we do and we want to in this case, where we're at an LDL cholesterol of 74, we want that to be below 55. We're at ApoB of 90. We probably want that to be below 60. I don't think ezetimibe is going to get you there. And so probably going for the PCSK9 inhibitor, especially in this patient with established atherosclerotic cardiovascular disease, very high risk. They're the kind of patient that we can get this drug for. You're also going to get triglyceride lowering from that drug. So I think that would be my next step. And of course, that could be inclisiran or a monoclonal antibody. They should both have similar effects.
Yeah, so can I just want to point out that, regardless of the guidelines, if you just think about what was achieved in the major randomized placebo-controlled clinical trials showing what happens when you add ezetimibe and showing what happens when you add a PCSK9 monoclonal antibody, in the IMPROVE-IT trial, when ezetimibe was added to a moderate intensity statin in patients with ACS, that they achieved an LDL cholesterol of 54 milligrams per deciliter, and they had event reduction, albeit quite modest because the amount of LDL reduction with ezetimibe is small. Whereas in the PCSK9 monoclonal antibody trial, in the Fourier study specifically, when you add evolocumab to high-intensity statin therapy in people with a stable ASCVD, like our patient, the LDL cholesterol dropped into that 30 to 40 milligram per deciliter range. So I just wanted, I bring that out because our goal of therapy is not to have the LDL cholesterol be less than 55. That's the threshold that tells us we need to do more. Our goal of therapy should be to achieve what was achieved in the RCTs, which was LDL cholesterol levels really in that sort of 20 to 50 range, and probably lower is better. You know, if you get to choose, are you going to aim more for 20 or more for 50? I would err on the side of aiming more for 20 whenever you have that opportunity for a very high risk patient.
So we don't very often have, or I should say, we don't as often have to deal with this, but from the practical standpoint, I recall times when we more or less were mandated by our payers to go to ezetimibe first. We've moved a little bit beyond that, but I still think we need to recognize that may be a practical consideration. Certainly, determining the goal that we need to achieve here, the PCSK9 inhibitor, is the best next step. I also want to be sure we don't forget about the importance of diet and lifestyle modification in this whole scenario, which is clearly something that is always the cornerstone of our management.
Yeah, this patient's triglycerides may suggest that there's more to do with diet, and maybe weight reduction or body mass index is 28, and
Right.
Certainly brings up some thoughts about other ways to address her care.
So let's move forward and see what we've addressed this to some extent as well, a treatment goal for this patient. Any additional comments on this? We've identified that she's very high risk. We know that LDL lowering as low as possible is ideal. Certainly we have to address the triglycerides as well. Any other comments on this from Dan or Nick?
Mentioning just because the triglycerides are above 300, she has diabetes, atherosclerotic cardiovascular disease, we should just mention icosapent ethyl, right? I think that's something that should come to mind because we do have a cardiovascular outcomes trial with Reduce It showing a 20% relative risk reduction in major adverse cardiovascular events. So I think that's something to consider, but I think the top priority, as Dan said, is lower the LDL first, and that should be the primary. And the triglycerides will come down along with the LDL lowering therapy. So high intensity statins, PCSK9 inhibitors, these both lower triglycerides along with diet and lifestyle interventions. Those should be trialed. You know, that should be first, second, and third on the list for patients with high triglycerides. You know, if you see the patient back and you've optimized their LDL on additional therapies, they've worked on their diet, they've lost some weight, and their TGs are still high, then maybe, you know, talking about icosapent ethyl is worth doing. Again, there is cardiovascular benefit there, but I think that it could be done in a stepwise approach at a follow-up visit.
And I think also most patients appreciate kind of that incremental management. So we're doing more or less one thing at a time, and that seems to be a good plan, a good set of action steps with most patients.
Yeah, you know, we were talking about the cost of some expensive therapies and this whole concept of discordance. And luckily in this patient, we were able to do a better LDL cholesterol calculation to make it an easier application for any potential therapy that we wanted from the payer. And we showed that her LDL cholesterol was actually over 70 and not in the 40s like we initially thought based upon the Friedewald formula. So that makes the authorization request a bit easier. Where it gets a bit tricky, we haven't come to the real nitty gritty of what we wrote in the paper, but you saw the table in certain, and it's sort of, there's a rub here, which is while we may think that LDL cholesterol is our primary target, and non-HDL cholesterol and ApoB are better targets, we may have some patients where we achieve excellent LDL cholesterol lowering, and LDL cholesterol below 55, where we think, okay, wow, they are below the threshold, but where we get their ApoB back or their non-HDL cholesterol back, and they're both above the typical threshold that we would want. And so if the next thing to do besides diet and inexpensive medicines is an expensive drug, we're kind of in a tough position because the insurer may not have read our paper and may not have bought into the same way of thinking. We can ask for permission to treat this patient with an expensive drug because we think there's value based upon the science that underlies this. But that doesn't mean it's readily accessible. And that's one of the shortcomings of making the recommendations that we did, is there is going to be this population where their LDL cholesterol is below the threshold for treatment and their non-HDL cholesterol and ApoB are above, and you're just not able to convince the insurer that that's the way to go until perhaps guidelines get rewritten and address this.
And also the other opportunity here is, given the high ApoB, optimizing diabetes management is going to be another way of helping our triglyceride lowering. So we have to keep that in mind. All of the risk enhancing factors for this patient need to be addressed. It's a matter of prioritizing and having those discussions with the patient.
Nick, at what stage do you add the icosapent ethyl? Do you first drive the non-HDL and ApoB down as low as you can, then consider the icosapent ethyl, or do you sort of do it in tandem? Sorry,
So I would.
Can't hear you.
Yeah, we lost him for a sec. I've had that issue with earbuds myself.
Mm-hmm.
How about you, Kaye-Eileen? Do you go for the non-HDL, LDL cholesterol, non-HDL cholesterol, ApoB first, then add icosapent ethyl, or do you sort of ratchet it down simultaneously?
I'll go with the "it depends" answer, and much of that is really on how I read the patient in terms of their comprehension of the number of changes that we're going to be making. And I certainly would first of all focus on the LDL, but and again, with a triglyceride level of 311, I might be tempted to focus on the LDL first, the diabetes management, and clearly set some standards as far as lifestyle management.
Can you hear me now?
Yeah.
Yes.
All right, great. Yeah, and I'll just add that, there is a third medicine, and another expensive one, or maybe hard to get, the GLP-1s, right? That you're thinking about with these kind of patients: diabetes, obesity, ASCVD, cardiovascular disease. We now have an outcomes trial with SELECT, and it actually lowers triglycerides by about 20%. So it's to the same degree as like an icosapent ethyl. And so that's another option if you're looking for, after you've kind of optimized LDL and ApoB and you want to lower the triglycerides and have cardiovascular benefit. Oftentimes I'm deciding kind of between icosapent ethyl and a GLP-1.
Right. Absolutely. All right. Before we get too far down that pathway, let's move ahead in our slides and have some further discussion on this.
So now let's get into the MNLA clinical consensus, role of ApoB in clinical management of adults, and how this fits into the case we're talking about. As a reminder, every atherogenic lipoprotein has one ApoB in it, but it's not always the same ApoB. For those from the endogenous pathway, the hepatically derived lipoproteins, such as VLDL, IDL, these will have the complete full form of ApoB, ApoB 100, but those from the exogenous pathway, intestinally derived, such as chylomicrons, chylomicron remnants, those will have the truncated form of ApoB, ApoB 48. But in our circulation, the vast majority are ApoB 100 containing particles. So, and the ApoB measurement actually captures both, but the vast majority are ApoB 100 containing particles. And as we discussed before, here's from another guideline, but both non-HDL cholesterol and ApoB are stronger indicators of atherogenicity than LDL cholesterol alone. So this is a message that we've got to discuss again and again. Now, in terms of the actual response to therapy, right now we have been talking about ApoB, non-HDL, LDL as indicators of atherogenicity, but not as a response to therapy. When we check the response to therapy here, we see a few examples of statins, ezetimibe, PCSK9 inhibitors, bempedoic acid, and then the percent reduction for LDL, non-HDL-C, and ApoB. We see that across all of them, first, the numbers are somewhat similar, which is not surprising because these are very correlated, but the reduction is always a little greater for LDL cholesterol compared with others. And that's because all these therapies act on the LDL receptor. So the reduction in LDL will always be a little greater than the reduction in non-HDL-C and ApoB that also include other particles. And please interrupt me at any time.
Well, I was just going to comment here that we're focusing on rosuvastatin and atorvastatin as our high-intensity statins. We know that there are other statins available. I think as lipid specialists, most of the time we gravitate towards these two. Any thoughts about other statins, whether it's a tolerance issue or some other concerns that perhaps our patients even bring?
I think other statins comprise less than 5% of my statin prescription. I think, the point of this table is really just to show that the LDL cholesterol reduction with all of these therapies is more than the ApoB reduction. I think that's the sort of key element of this finding, and it leads to an interesting LDL cholesterol ApoB relationship that Nick really laid out for us beautifully with the table from the figure from the paper. Andre, I can't remember if we have that figure to show this evening, but yeah. So maybe Nick can take us through that relationship a little bit. So it follows from the therapeutic reduction in these.
Yep. Yeah, we can take a look at that. And we basically took data from the Fourier trial and the Approve It trial, which are obviously trials of patients that are on all patients are on statins, and then we've got an arm on ezetimibe and an arm on PCSK9 inhibitors. And so we focused on kind of an on-treatment population. If you can go to I don't know if it's an upcoming slide with the plots. Yeah, here. So if we focus on the middle plot, this is basically plotting patients on therapy, either statin only, statin plus ezetimibe, or statin plus PCSK9 inhibitor. And then we kind of plotted a linear regression here to get a sense for, what would be an equivalent ApoB value for a given LDL cholesterol value. So if you just look at the middle of the plot, LDL cholesterol of 100, and follow that up to where the red regression line is, that gives you an ApoB of about 90. But you can see that there's a large spread, a large range of ApoB levels at an LDL-C cholesterol of 100. And so this gets into the issue of discordance. You can see the ApoB may be as low as 75, it may be as high as 125. So, 40, 50 point spread for a given LDL cholesterol, just speaking to how many patients may have discordance. Now, if you're above that red line and you have an ApoB that's higher than what the LDL would predict it to be, then you have elevated ApoB discordance and you have elevated risk that's not appreciated by the standard lipid panel. Those are patients that you may want to treat more aggressively. And then as we get kind of lower LDL cholesterols, what we find is that when you treat patients, basically you're depleting the cholesterol and the particles more so than you're reducing the particles. And so while both will go down, you will have greater reductions in the amount of cholesterol relative to the amount of particles. So that is why you see what we saw in the last table, where the reductions in LDL cholesterol are greater than ApoB. So I think this is informative in kind of picturing the discordance, picturing that there are patients out there where LDL cholesterol is not capturing the whole picture.
It's also why there's two lines here. So just want to point out panel A represents untreated adult patients from NHANES, and panel B represents those treated patients that Nick just described. And when you combine them onto panel C, you see the red line and the green line, or those of you who aren't colorblind can see the two lines, and we'll see that there's a relationship between LDL cholesterol and ApoB that's different in treated patients compared to untreated patients. They're in parallel, and it's because you get more LDL cholesterol reduction when you upregulate LDL receptors with the medications compared to particle reduction. The thought is that the cholesterol enriched particles seem to have a higher affinity for the LDL receptor. So you're probably clearing cholesterol enriched particles more than the cholesterol depleted particles. And so that's why the LDL cholesterol tends to go down.
Very important point. So Andre, shall we move forward here?
Yeah, I was wondering if Dr. Soffer and Nick could walk us through how they decided on these thresholds, because at the end of the day, in the guideline, you want it to be practical for people to have a number, put this table in their office and make a decision out of it. So could you walk us through how you reach these numbers?
Yeah, I can try, and maybe Nick will throw in his 2 cents too. So when we looked at the two regression lines, we were able to see that there was probably an average regression between LDL when looking at LDL cholesterol and ApoB, and we really wanted to make sure that we were going to use equivalent ApoB readings to correspond to the LDL cholesterol that was called out in the guideline and in the expert consensus decision pathway for treatment. And you can see they land pretty close to each other from a milligram per deciliter range. So for an LDL cholesterol of 55, that falls out as an ApoB of 60. And for an LDL cholesterol of 70, it's also 70. And for an LDL cholesterol of 100, it's an ApoB of 90. These are estimates. They are approximations. You can see with all these scatter points and the linear regression, it's still just an estimate. We did opt to use numbers that were whole numbers, easy to remember. We didn't think that having an ApoB of 58.7 was going to be a memorable enough number to be useful clinically. And so we rounded up to the nearest whole number that ends in 0 or 5. It turns out they all ended in 0. And then I just want to add that Anne-Marie Navarre and group of authors published a fairly similar work about 1 or 2 months before our paper was published. And they took an even more practical approach using a similar analysis. And what they found is that these numbers, the LDL cholesterol and ApoB, are so close together that it actually it wasn't really going to add enough to the clinical care to have different numbers, and that it would be more memorable to use an ApoB of 55, an ApoB of 70, and an ApoB of 100. Even though their mathematics was roughly the same as ours, they just felt that it was a more practical approach, and I applaud them for taking a very practical stance. And I also, again, want to call out Nick and his team for having really run all this data and really made sure that it was as accurate as possible. I think we really stayed faithful to the data in putting this together.
I'm going to jump to a couple of the questions that have been coming in from the audience because they're relevant to this particular discussion. One question, well, actually from several, could we not look at triglyceride over HDL as a poor man's way to identify small LDL particles and save an ApoB test?
I don't think that's the same thing. I think if you want to use a free test, you don't have to invoke ratios. Non-HDL cholesterol is excellent.
Agree. I certainly support that in my practice as well. Another question here that's a little back to some of our prior discussion. LDL cholesterol of less than 55 in this question was associated with only 2% reduced risk. How clinically relevant is it given the number the high number required to treat?
In the Reduce It trial, yeah, I would say that the findings from Reduce It are underwhelming, but they favor the LDL lowering hypothesis. So if you remember, that population at the 7-year mark in the trial had a 1/3 rate of cardiovascular events in the placebo group, and it only came down by about 2% from that number by absolute risk reduction. So it's not a huge risk reduction over 7 years. And that's because ezetimibe is not a potent LDL lowering therapy. It's also because atherosclerosis is complicated, and LDL particles are the building block for atherosclerosis. Even if you make it go to zero, the patients are not going to, the risk doesn't go away. There's so many other aspects of atherosclerosis that lead to events. And so using a lower potency therapy is going to have a modest impact. I have no concerns about the cost efficiency of ezetimibe, though. It's cheap as dirt, safe and well tolerated. And when it was an expensive branded drug, I didn't use it very much. But now that it's an inexpensive generic drug, it's quite safe and easy to use. I'll take every little bit of LDL cholesterol reduction we can get.
All right. That certainly is very consistent with what our guidelines tell us. Let's move forward in the slides. Andre, any recap on from our panelists here on what our key points are to take away from this discussion?
I can go through these. So key points from the clinical consensus. Number one, ApoB, non-HDLC, and LDLC are all measurements that represent the lipid lipoprotein contribution to ASCVD risk. Two, discordance between ApoB and LDLC and non-HDLC and LDLC is common, as we have been talking about. Number three, with discordance, ApoB and non-HDLC correlate more closely with ASCVD risk. And finally, ApoB thresholds may be considered for treatment intensification.
And along those lines, I have another question here from the audience. Stating my practice usually orders ApoB for patients who have a high LDL or an elevated calcium score. Would you ever see an elevated ApoB with a clean heart scan, which I assume means a CAC score of 0? Should we test ApoB on patients with normal LDL or coronary calcium scores of 0?
Yeah, that's a great question. I can start. You will see patients with all sorts of lipid abnormalities and have a totally normal scan in terms of plaque, whether that's a coronary artery calcium score or a coronary CTA, coronary CT angiogram. And part of that depends at what age you're testing them, because plaque develops over time. And the older we are, the more likely we are to have plaque. It's the strongest driver. But that said, I have patients even with FH, high LDLs throughout their life, untreated or non-optimally treated, who have gone on with high LDLs and they'll have a CAC score of 0. So, there's other factors at play. That's definitely the minority, though. Most likely you'd expect to see plaque, but there are other potential protective mechanisms, in the endothelium, genetic predisposition, something that could protect you. So it's not a guarantee to have plaque, but it's certainly a major risk factor to have increased plaque burden. And we know from the trials that if you have higher LDL, higher ApoB, you're going to have higher likelihood of increased degree of plaque burden.
Very good. Looking at some additional questions here also in alignment with the discordance concept, and going back to what we discussed at the very beginning here, What are the indicators to suspect a breakdown in the Friedewald estimation of LDL cholesterol other than in low LDL and high triglyceride situations? In other words, what's going to help us think about using alternative measurements?
Well, I'm always in favor of using ApoB or non-HDL cholesterol first, but if you're gonna rely on the LDL cholesterol, you might as well use the ones that are easiest to access. And if your preferred laboratory is still using the Friedenwald, there is a mobile app for using the Martin Hopkins formula. So it requires an extra step of going to the mobile app if you really want to see what the LDL cholesterol is. But primarily the issue is at very low levels of LDL cholesterol and elevations in triglycerides by even a modest amount.
Well, that's a perfect segue into one of our last questions here. Knowing that PCSK9 inhibitors will significantly lower the LDL when we're lowering ApoB, how low is too low?
Yeah, that's a great question. Fortunately, we have a lot of data to kind of help answer it and kind of reassure people who may be concerned. So the Fourier trial, as Dan had mentioned earlier, the treatment arm of that trial achieved a median LDL cholesterol of 30 milligrams per deciliter, but there was still a large chunk of patients, like 25%, who achieved LDL cholesterols below 20 milligrams per deciliter. And that group had no significant increased side effects compared to the placebo arm. Additionally, there was an open label extension that went on for 7 or 8 years of follow-up, and these patients were monitored with LDLs below 20 and still no safety concerns. And we know because ApoB was also lowered significantly and to similar degrees in that group, that the same can be said for ApoB. So lowering ApoB, LDL cholesterol, non-HDL cholesterol to very, very low levels appears to be safe. And you see continued benefit to Dan's point. It's not just get to 55 and stop. We see continued benefit, cardiovascular risk reduction, the lower we go, even beyond 30 or 20 milligrams per deciliter. So hopefully that helps allay any concerns that people have.
And now that we have been using the PCSK9 inhibitors since 2017?
2015.
We have a lot of longitudinal data that really supports that as well. So I think we have time for one more question, and this is an interesting one. And it goes back to the shared decision-making concept. How do you convince a patient to be adherent to stronger high-risk treatment goals when they are secondary prevention due to a high coronary calcium score, but have no prior actual clinical ASCVD event?
Well, I find that it's in some ways, it depends on the patient, but in some ways it's easier because you can actually show them the pictures of the plaque. And if they've had an event, sometimes they feel like they had the stent and they're fixed. But if you show them all the plaque they have and talk about how high that number is and what percentile it puts them in, and the idea is that plaque could rupture and we want to prevent that first event, I find that to be pretty powerful in getting patients to buy into starting statins or intensifying beyond that.
All right. And maybe, do we have time for one more question, Dr. Meyerson?
30 seconds.
All right. So this question just revolved around, in general, ethnic disparities between LDL and ApoB thresholds.
Sorry, say that again.
There was one question here in regards to specifically Latin American patients or non-Caucasians. Cutoff points for non-HDL and ApoB similar to guide us as far as cardiovascular risk, or are there discrepancies there?
I don't know the guidelines from other countries, but human biology is human biology. You want to make the LDL go low if someone's at high risk.
Lower is better for longer.
And on that note, I want to thank everybody for joining us this evening. We had a very stimulating discussion. I want to thank Nick Marston and Dan Soffer and Andre, Kaye-Eileen for really bringing home ApoB and how we can use it clinically and how we need to think about it, as well as non-HDL cholesterol. The lipid panel will be rejoining in full in January of 2025. So we want to wish everyone a very happy Thanksgiving and happy holidays, and we look forward to seeing you in the new year. Thank you.
Thanks, everyone.
Thank
You guys
you.
could be going all night here, Dan. We got about 25 questions. Great job. Great job.
Yes. Thank you, everyone.
Thank you.
Thank you.